now. No. So I'm Mohammed Lasmar. I'm one of the senior clinical fellows in Salford, Manchester. I'm privileged to of being invited by Mr. Harby to join the MRCS Osce course. I do general surgery and upper GI surgery in my work. Have an interest in teaching. I teach in some international courses like ATLS, CRISP, basic surgical skills, and some basic laparoscopy courses as well. And as I said, I have interest of teaching, and that's why it's a great opportunity to join you in this course. I will start today in speaking about the GIT topic, the gastrointestinal tract, and how might the Osce station run in this topic. I'm not going to discuss the whole GIT today, but I'll discuss, one or two topics. I will start, as we always start, with a case scenario. So if you have a 45-year-old male came to the emergency department with hematemesis. On examination, he found to be jaundiced or icteric, and he has shifting dullness or distended abdomen that contains fluid. Has background history of excess alcohol, and he had 2 attacks of hematemesis. So anyone have question, have any ideas what you might do for this guy?
Doctor, sorry, that I just know from my MRCS party knowledge that with the hematemesis and with the vomiting, in fact, there will be hypochloremic, hypokalemic metabolic, the alkalosis.
Okay, so I'm just asking what you would do for this patient.
Okay.
Can I answer?
Yes.
I think we should first of all stabilize the patient by ABCD. Then we should reinvestigate the patient for hematemesis and vomiting.
Okay.
Yes.
Okay. So yeah, in such cases, when you have a case like this in the exam, you have to have a plan of answering the question and answering the management. And you've done very well. This is a very good answer, but we need to have a plan. All of us need to have a plan. So the plan usually to follow what we call the CRISP approach. Okay, so you can use this flow chart in a lot of cases, not only just bleeding. Okay, you can use it in peritonitis, in unwell surgical patient actually. And this unwell surgical patient can be inpatient, or can be a new presentation like this case, like the hematemesis. So how do you think, as you said, exactly, Dr. Isra, exactly what you said is to start by A, B, C, D, E. Okay, that's the immediate management. That what you're going to do in the emergency department and when you first see the patient. And then you will have some time to go through the patient chart if the patient is admitted, or take some good history, and maybe you can do some investigation and request some bloods and all these things. And sometimes in the exam, you can ask for these bloods and they can give you the results, okay? And then after these first 2 steps, you have to think, is this patient stable or unstable? Sometimes you might not be sure, okay? And according to stable or not sure versus unstable or not sure versus stable, you have to decide now. You have to do something for this patient, okay? And in order to have to do something for this patient, you should have a diagnosis. Okay, so there is a diagnosis required, as you can see at the top right box, and you have to have some ideas about the definitive management, which will have maybe just medical management. You need to think about the level of care. you're going to put this patient, does this patient suitable for a ward care or high dependency unit or critical care, okay? And you need to speak to some people about that. You might need to refer the patient to critical care or speak to anesthetist or whatever. Sometimes this patient might need a surgical management, okay? An operation, okay? Sometimes the patient might need intervention, like as we say to the patient's camera test or endoscopy or interventional radiology or radiological intervention, as I said, okay? So you need to think about all these things. If the patient is stable, you go for the daily management plan, which is SOAP approach, and we'll speak about it later, okay? So that's the plan. You can, you know, when the examiner asks you about what are you going to do for this patient, you need to have this flow chart in your back of your mind, okay? You start by ABCDE and go for more history and investigations, and then decide, or the examiner will ask you, is this patient stable or unstable? And accordingly, okay, you will do your plan, which in the critical care stations or the physiology stations to be something, you know, you will do something, okay? It's not going to be a daily management plan. Okay, so we'll use that throughout this lecture and throughout the GIT. It can be used. Okay, so what, for example, what we're going to do for ABCDE, as Dr. Isra said, for EMP, usually the management is similar. You put for all these unwell surgical patients oxygen mask with high flow oxygen. And it's for all of them, okay? So the oxygen mask for the unwell patient is mandatory. You have to put an oxygen for them. Although sometimes they are saturating well and everything is fine, but you have to put the oxygen mask. That's to maximize the oxygen delivery. And you will speak about the oxygen delivery later. There is a formula for the oxygen delivery. And you need to maximize this. And in this specific patient, he's vomiting and he's vomiting blood, so he's bleeding and he's vomiting. So he might be in profound shock, and patients in profound shock can have disturbed conscious level, okay, especially in grade class 4 shock, and he's vomiting, so his airway is threatened, so you might consider intubation, okay? Of course, not all of them would be intubated, but you have to make the examiner aware that these patients sometimes might require intubation to protect their airway, okay? But the mandatory thing is the oxygen. When you go to C, okay, you have to have an access. You have 2 cannulas for this patient, 2 wide pore cannulas, okay? And you have some cross-matching and blood products, okay? And the idea with the C is about shock, basically, and I'll speak about this in details as well. In some hospitals, and if the patient is very unwell and very unstable, you might activate the major hemorrhage protocol. This is one of the key words. You need to make the examiner aware that you know this word, okay? We might need to activate the major hemorrhage protocol, okay? And cross-match and some other blood products. And D, you have the GCS of the patient. And when you assess the GCS of this patient, the examiner might ask you, why might the GCS of this patient might be impaired? What's the implication of that? Okay, and that's a question. That's an Osce question. Why this patient might have a disturbed conscious level? Okay, anyone have an idea why this patient might have disturbed conscious level? Okay, I will tell you there are two reasons this patient might have disturbed conscious level. One simple, profound shock, class 4 shock, hemorrhagic shock, he's bleeding. And the other one is...
Second, electrolyte disturbance, I think.
It can be, but that's what... The examiner is not waiting for this answer. The answer will come later, okay? Don't worry.
Okay.
Okay, so from what I told you, you've done the ABCDE, okay? From what I told you, is this patient stable or unstable? Let's go through the patient again. Is this patient stable or unstable? You can ask.
Looks like he's unstable.
The patient's unstable, okay? And you can ask about vital signs and things like this. So he's hypotensive, he's tachycardic, and all these things, okay? So he's unstable. So what are you going to do after the ABCDE? This slide is speaking about shock, okay? And in C, when thinking about circulation, you are thinking about shock. And the question might be, is this patient shocked? He's diaphoretic, he's cold, he's hypotensive, he's tachycardic, and he's oliguric, okay? Or combination of all of these. Is he shocked? You have to answer here, yes or no. And examiner might ask, what is the definition of shock? I might ask, what is the type of shock this patient have? Okay, so all of these might be questions the examiner might ask. Okay, I will take you through this slide in details later as well. Okay, so this patient is shocked. You decided that this patient is shocked and a diagnosis is required. Okay, so another question might be, what might be the diagnosis?
Looks like he's in hypovolemic shock.
Why he's vomiting? Why he's vomiting blood? What is the diagnosis?
Esophageal varices.
It can be, yes. Anything else? That's exactly
yes, he
what
is
will
alcoholic.
say. He will say, yeah.
Mallory-Weiss syndrome.
Okay.
Sorry, Mallory-Weiss type.
Okay, definitely. Okay, what
Or
else?
portal hypertension because of alcoholic abuse, maybe liver cirrhosis and portal hypertension.
Okay, so this is the same, you know, portal hypertension causing esophageal varices and hematemesis. Yes, you are all right. Anything else?
Gastric ulcers, erosions.
Gastric erosions can be, yes, of course.
Is there any crepitations in the thoracic cavity because of the Bohiver syndrome?
Okay.
Is there any rupture of the esophagus?
Yeah, I'm aware that Boerhaave syndrome is written in some sources as a cause of hematemesis, okay? I see Boerhaave syndromes at least every week once, okay? I know it's rare, but I work in the referral center for esophagogastric surgery, okay? And I've never seen a patient with hematemesis, okay? That's not right.
Okay.
Boerhaave syndrome is not a cause of hematemesis, okay? Theoretically, maybe, but it's not really a cause of hematemesis. I'm aware it's written in some sources. It's rare, okay? And that's why not, you know, not all of people are very familiar with it. Okay, I will now I gave you a plan for management. I will give you a plan for a differential diagnosis, how to plan for a differential diagnosis, how to answer differential diagnosis. Okay, so the plan is you know, one easy thing is this box at the right upper hand side of the screen. Think anatomy, then pathology. Okay, as easy as that. Think anatomy, then pathology. So what might bleed from the upper GI tract? Might be esophagus, might be stomach, might be duodenum, might be other things. Okay, and then think about pathology in each one of them. Might be trauma, so iatrogenic injury of esophagus can cause hematemesis. Major trauma, okay, can cause hematemesis, or violent vomiting that can cause Mallory-Weiss and can cause hematemesis, can cause vomiting of blood, okay? Major trauma including penetrating injuries like gunshot, shotguns, stabs, and stuff like this, okay? Esophagitis, can people with esophagitis vomit blood? Yes. Neoplasia cancer, yes, we see people with esophageal cancer that can vomit blood, and varices, okay, which is, as you said, is the likely diagnosis and the first thing you mentioned. Again, go for stomach and go for, you know, pathology, trauma. Not a common cause of bleeding, but I've seen it myself after shotgun. Someone was bleeding heavily, hematemesis, a lot of hematemesis from stomach. Ulcers, which is a very common or a very well-known thing, and neoplastic gastric cancer is something very well known for hematemesis, especially GEST, by the way. The GEST tumor is very well known for bleeding, okay? And vascular, maybe dysplasia and varices, vascular dysplasia or abnormalities is a very well known in the stomach, and varices is well known in the stomach. Duodenal, the very famous is the duodenal ulcers, okay? Definitely they bleed, okay? And they can cause major bleeding and hematemesis. And I will ask you just an opportunity here to ask you what vessel might be involved in this bleeding. Anyone aware about what
GDA,
artery?
GDA, perfect.
Yeah.
I've heard, you know, some noise, but I'm sure it's, you all said GDA, gastroduodenal artery. Okay, perfect, well done. And neoplastic vascular trauma, not very common, but it can happen in duodenum. Okay, some other things you need to think outside the box, and these things really happen. Swallowed blood from nasal injury or nasal bleeding or pharyngeal bleeding, and hemoptysis sometimes can be confused with hematemesis and coagulation disorders, and some people in antiplatelets or dual platelets on anticoagulation therapy after heart attacks and these things, sometimes they bleed. It increases the risk of upper GI bleeding. Okay, so how are you going to answer? Are you going to answer like this, in this order? I don't recommend that you answer in that order, okay? But what I recommend is to have this plan at the back of your mind. What I recommend is to start answering by the most likely diagnosis, okay? And after that, the working diagnosis or the other diagnoses that you want to exclude, okay, to prove or disprove the diagnosis, okay, and then carry on with this plan, okay? So in that specific case, I would answer like this. So this is most likely a bleeding from esophageal varices, okay? But it can be bleeding from duodenal ulcer or vascular dysplasia or gastric erosion. If the examiner stopped you, that's fine. If the examiner didn't stop you, you can go through the plan again, okay? You go, okay, and in addition to that, it can still be because of trauma to the esophagus, because iatrogenic entry, most likely OGD or upper GI endoscopy, can be because of major trauma, but this patient doesn't have a major trauma. This patient might be had a vomiting and malarivitis, might be esophagitis, you know. So this is the next step. So you can divide your answer in three things. One, the most likely. Two, the things that can confuse you or you need to exclude to prove or disprove your diagnosis. From the most common to the less common, basically. And then when you stop or run out of common things, okay, you need to go through this plan. Okay, so now you know how to answer this question. So that's most likely a bleeding from esophageal varices, but can be a duodenal ulcer or gastric varices or dysplasia, or, okay, if the examiner will stop you. If they didn't stop you, carry on saying the other stuff. Okay, so again, can anyone tell me what's the most likely diagnosis of this case? Easy, isn't it? So it's exactly as I said it, okay? So you don't need to repeat it. What are the concerns about this patient? Anyone have any concerns about this patient?
He's in a shock, so he can develop kidney failure?
Yes, that's a very, very valid point. He's in a shock, okay? So bleeding, number one, okay, that can kill him. okay? And next thing is kidney failure, okay, because of his hypovolemic shock. So shock, AKI or hepatorenal syndrome, encephalopathy, okay? They can develop encephalopathy and coagulopathy because their liver is failing, okay? So now we can go back to the written note, okay? So it's my aim here is to make your mind systematic, okay, and to how to run with the examiner throughout the station, okay. Questions and answer, Mr. Harvey wrote them very, very, very nicely in his notes, okay. So we can go through this. So now you can say yes, shock, coagulopathy. When you reach to that point, okay, you've done very well in the first part of the station. The examiner knows that you have a system, know what you are saying, and then he will start asking about the physiology and the critical care core questions. Okay, so shock, coagulopathy, hepatic encephalopathy, hepatorenal syndrome, and AKI, definitely. So now, what would you do for this patient? We're here now. We've done the ABCDE. We know now that the patient is, and we had the history, and we've done some investigations, and we know now that the patient is unstable, and the examiner will take you now for the definitive treatment for this patient. You know now the most likely diagnosis, okay, which is probably bleeding varices, and the examiner will quickly ask you about the definitive management, okay? And as I told you, you can just divide it like this: medical, surgical, interventional / radiological. Okay, I need to think about the level of care that this patient will be admitted in. It will depend upon the patient numbers, of course. Okay, so what would you do? As you can see here, this depends on the diagnosis. Okay, and we're aware that this might be it's most likely a variceal bleeding. So it's the OGD, okay? They call it OGD here. Some people call it upper GI endoscopy. It's endoscopy, basically. You can say endoscopy or gastroduodenoscopy. So what you are going to do in endoscopy? I will do band ligation or sclerotherapy, okay? If you don't have endoscopy, or I put endoscopy twice here, okay? Because if you did the endoscopy first time and you did the band ligation or sclerotherapy and the patient re-bled again, the next step is endoscopy again, okay? And that's why I put it twice. If you don't have endoscopy, you can tamponade it. You can stop any bleeding with pressure, okay? And I will tell you how to tamponade this. If you are desperate, or the next line or the other line is tips, you can say tips and the examiner will ask you, okay, you know, sometimes these are tricks in the exam. You can throw the question to the examiner, okay? So you can instead of saying the next step will be transjugular intrahepatic portosystemic shunt, you might say tips, okay? That here you are giving the examiner a question to ask, and you are buying some more few seconds in your station, okay, with the right answer. So when you say tips, the examiner will ask you what is tips, and you start saying, okay, that's transjugular intrahepatic portosystemic shunt. Okay, I don't think they will ask you how it's done, but it's written in the note. You can have a look at it. I will take you through the notes quickly now. Medical, the terlipressin you can use to help you stopping the bleeding. Surgical, there are few shunt operations. It's very old operations, not done anymore. Splenorenal shunts and stuff like this. I don't think anyone will ask you about these, but there were some shunt operations done before, okay, but they are part of history now. Okay, so examiner can ask you, so what if you did endoscopy and it's not bleeding varices, if it is bleeding DU, duodenal ulcer, I mean, okay? It's the same way of answering, okay? There's not a lot of differences, okay? you'll do an OGD, and if the patient bled, it's an OGD as well. So what we're going to do for an OGD, okay? It's normally, it's called dual therapy, okay? It's called dual therapy. You do two things. You inject adrenaline and you use something mechanical or thermal, okay? And some people put hemospray like fibrin or thrombin on the bleeding vessel or bleeding ulcer, okay? So if you, the word dual therapy is a key word. If you said dual therapy, you are throwing a question to your examiner to ask you, so what is dual therapy? You'd say adrenaline plus mechanical or thermal intervention, okay? Like that therapy, okay? So about the next step, it's OGD, and next step is usually embolization of the vessel, okay? If not available, the embolization, some centers not available, you will go for surgical option, which usually will be the ligation of the DGA, okay? So upper GI bleeding, to be honest, in real life in the UK is, it's a gastroenterology or a medical admission, okay? But we still see them, and still very classical topic in the MRCs and surgical exams in general, okay? It's a very classic topic, okay? But in real life, it goes to the medical team normally, okay? But at some point, they might ask us to join, especially in bleeding duodenal ulcer, and they need a ligation of the GTA. Okay, this is some staking Blackmore tube. You can have a look here, and you see few lumens, one for aspiration. It's like an NG tube, okay, but it's not an NG tube, obviously. One to aspirate from the stomach. So this port is connected to these openings, and one to inflate inside the stomach, and one to inflate in the esophagus. Well, basically, this is the tube that you use to tamponade or to compress in the bleeding. Okay, so that's the Sung-Staken tube. There is a specific way of putting it and filling it and some pressure, but the idea is easy. Put it in the stomach, fill the gastric balloon, okay, and then pull it out till you make the balloon snug to the against the hiatus or the gastroesophageal junction. Okay, so now you close the gastroesophageal junction, and then you start inflating the esophageal balloon to compress the bleeding in the esophagus. Obviously, you might have now, all of you, some worries about this balloon, because if you increase the pressure or left it for a lot of time, it can cause pressure necrosis. Okay, so you need to know the numbers and all these things. I'll go through them quickly with you now. Okay, I will leave that as a homework for you. Just think about it. We'll go through the topic, don't worry, but think about it. What might be an Osce station in MRCs about lower GI bleeding or bleeding by rectum? Okay, what might be the questions, and how are we going to answer these questions? How are you going to think about differential diagnosis? How are you going to manage an unwell, shocked patient with lower GI bleeding? I will leave that with you. Okay, but I will go quickly to stop something here.
Yeah, go.
Okay, guys, so I showed you the notes and the other questions and what might be asked about this case. I will go to another topic now, which is abdominal pain or perforations. Okay, so we might have a case discussion, a case scenario like this. A 46-year-old male smoker with osteoarthritis or non-steroidal anti-inflammatory drugs, presenting with peritonitis. Can be, very explicit like this, but sometimes they just give you, just say abdominal pain, and you go through the examination and they tell you the findings. Okay, that might be a case of discussion. You might be thinking now about the diagnosis. So what might be diagnosis in this case?
Doctor, the NSAID could have caused the GI ulcers or the duodenal ulcers, and that would have caused a rupture and a bleeding and then a peritonitis.
Okay, so it's probably a perforated duodenal
perforation.
Okay? Again, I'll just read those to you. Okay, that's a teaser for you, just something to think about. Okay, so we had a case of 62-year-old lady presenting with sudden onset left lower quadrant pain and some signs of peritoneal irritation or peritonitis in the left lower quadrant. What might be the diagnosis?
Could be diverticulitis.
Okay, fine, might be. And 25-year-old male presented with right lower quadrant pain and tenderness. What might be the diagnosis?
Appendicitis.
Can be, of course. And 35-year-old lady presenting with right upper quadrant pain.
Could be ovarian torsion or ruptured ectopic pregnancy.
Okay, it can be, of course, I agree. But it's just this stuff for you to think. 72-year-old male presenting with left loin pain. Okay, I like this silence.
Hernia. No. Or volvulus. No, if loin is not a volvulus.
Loin pain.
Could be pyelonephritis.
Okay, just think about it. 57-year-old lady presenting with severe epigastric pain.
Pancreatitis.
Can be, I don't disagree. 65-year-old male presenting with severe epigastric pain. Smoker. Okay, I like the silence again. That's good. 5-year-old boy with lower abdominal pain and diarrhea.
Gastroenteritis.
Can be, okay. These things are for you to think, okay? And I will take you through them again, don't worry, okay? This is just the start of this station, what might be discussed in this station about GI perforation. So regarding this case, how are you going to manage the case? Is the same. As long as you have the system in your mind, okay, you just start with ABCD, you'll put oxygen mask, you will see if this patient is shocked or not. You need to think about what type of shock, okay? And I've not spoken to you about shock today, okay? And about the conscious level and the examination of the exposure. And you go through the history and then decide if the patient is stable or unstable and what are you going to do for this patient. Okay, this is a way to think about diagnosis. So it's a lot, isn't it? That's the abdominal pain or the differential diagnosis of peritonitis. Okay, it's a lot, but as long as you think anatomy, then pathology, okay, it's not going to be difficult. Okay, and the trick I told you is to give the most likely diagnosis and the diagnosis you want to exclude. Okay, and then go through this flow chart. Okay, you can give the examiner, I don't know these how many, but these might be 20 or something. That's a lot, isn't it? You can give him 20 differential diagnoses, okay? But the examiners don't like that, okay? You need to start by the most likely, and you need really to highlight the things that you need to exclude. And you will see with the examples we've discussed, very important things we need to exclude, okay, in these cases. And if you just give your examiner the answer in that way, okay, they will be happy and they will help you or they will pass you, okay. and they will start asking you about the physiology and the critical care questions, okay? But if you have a strong start, that will be really helpful, okay? So what might be the cause? Trauma can be a cause in the stomach, duodenum, seen blunt traumas and road traffic accident causing peritonitis and stuff, but this case didn't come with trauma, okay? So you can exclude trauma from that. Can be gastric ulcer, can be perforated gastric ulcer or just gastric ulcer, can be malignancy, perforated malignancy, it can be perforated DU, okay? This case, especially the patient have non-steroidal anti-inflammatory that can cause a duodenal ulcer, and this will be the start of the station, and then they will ask you how can that cause a duodenal ulcer. Can be neoplastic, can be duodenal cancer or other cancer from the pancreas or something causing duodenal injury. Can be pancreatic or biliary, okay? Severe cholecystitis, sometimes deperforate, okay? That can cause perforated gallbladder, okay, from acute cholecystitis. Can be cholangitis. I've just put 2 question marks. Does not usually cause peritonitis, but can cause peritoneal irritation, definitely, but not that picture. Pancreatitis can be very easily mixed up with peritonitis, okay, and perforated DU, and that's why it's mandatory to ask for amylase, especially with upper abdominal pain, okay? That's mandatory, okay? That's something you should never miss. Because it will be a catastrophe if you took a patient for laparotomy and you found the patient just have some funnication because of the pancreatitis, okay? That's mandatory, that's a critical point. Small bowel can be inflammatory bowel disease. Please don't forget that, okay? I worked a few years in other countries outside the UK, and I rarely saw any case with inflammatory bowel disease, but it's very common in the UK. So you have to bear in mind this is something you need to exclude. This is one of the things you need to exclude, okay? The inflammatory bowel disease. Neoplasia, not very common. Small bowel strangulation can happen because of hernias, internal hernias, or because of adhesions or obstruction or whatever. Appendix, very rarely the trauma to appendix, but anyway, that's why I didn't bought it. Inflammation, appendicitis, sometimes neoplasia in the appendix. Clonic can be trauma, can be still IBD, inflammatory bowel disease. It's IBD, not IBB. IBD can be infective colitis, can cause picture similar to peritonitis or when you have a severe inflammation, can cause sometimes perforations and dead colon actually. And ischemic colitis can cause a picture like peritonitis. Perforated diverticulitis, very common. The diverticulitis itself, diverticular disease, is very, very, very common in the UK. So this is something really important. Again, as I told you, I've worked in other countries. I rarely seen any case of diverticular disease or diverticulitis in other countries, but it's very common in Western world. Okay, sometimes they consider it as a normal variant. Perforated tumor, common. I'm not saying common, but it's a very well-known thing, and we see it every now and then. Perforated tumor causing peritonitis and strangulation because whatever, volvulus obstruction, hernias or something. And you need to bear in mind that there are other non-GI causes. Okay. AAA. Okay. You can say AAA in the exam. It's a very well-known term in UK, but I would prefer to say aortic aneurysm or ruptured aortic aneurysm. MI, myocardial infarction or cardiac event, can cause abdominal pain, okay, especially inferior MI because they irritate the diaphragm. They can cause epigastric pain, okay. Pneumonia can cause upper abdominal pain, definitely, okay. Metabolic, some other metabolic things can cause abdominal pain like ketoacidosis. Ectopic pregnancy, okay. can cause abdominal pain, lower abdominal pain in women in childbearing period, and urological can be, you know, stone or pyelonephritis or whatever, and others. There are a lot, you know, you can list a lot of causes of stuff that can mimic peritonitis or can cause peritonitis as a differential diagnosis of peritonitis. Okay, so you might think about other things now. You might change your mind about your answers, okay, regarding this case a little bit, or change the way that you're going to answer this case. Okay, just change the way. Okay, so when I tell you there is a 46-year-old male smoker with osteoarthritis and non-steroidal anti-inflammatory presented with picture mimicking peritonitis or severe abdominal pain with tenderness, rebound tenderness and things, you might change your answer a little bit. Okay, you might say it's likely that this is a perforated duodenal ulcer, but it can be what? Or I need to exclude what? You need to exclude what? Something very important. I spoke about it in the last slide. So that's how you will.
A pancreatitis?
Exactly. You need to exclude pancreatitis. It's unlikely, okay, but you need to exclude it, okay? Because you don't like to go open someone up and just find they have pancreatitis. It's unlikely, okay? The clinical picture is not suggestive, but if you have a patient whose MLA 2000 or something, you'll change your mind. You might go for a CT scan or something else to you know, to roll in, you know, or to prove or disprove your diagnosis. Okay, so that's the good way of answering this case. So it's likely to be that, but I need to exclude that by just requesting amylase. So I will do amylase. Okay, and now we can think about other things now. Okay, so this 26-year-old lady presenting with sudden onset lower quadrant pain. So it's likely to be diverticulitis or perforated diverticular disease or complicated diverticular disease, okay, but it can be torsion ovary, okay, or volvulus, but this will be associated with symptoms of intestinal obstruction. That's how you answer. If you said volvulus, you say, but this will be associated with symptoms of intestinal obstruction, or you can go through the rest of differential diagnosis. Most likely the examiner will stop you here, okay? Because he knows that you know, okay? You know what's the most likely and the things that you need to exclude. And this 25-year-old male presenting with right lower quadrant pain was the most likely, and what you want to exclude? The most likely you said it's appendicitis, isn't it? What do you want to exclude here? It's
torsion.
You know, it's it can cause lower quadrant pain, yes, but it's unlikely. They usually will come with scrotal pain. Okay, if you want to exclude
stones or UTI.
It can be, yeah. That's why we routinely ask for a urine deb for these guys, okay? And because it's not in your mindset, okay, and it's more common in Western world, you need to ask about his bowel habits and if there is any diarrhea or anything in the recent few years or any family history of IBD, because this patient might have Crohn's, terminal ileitis, okay? So that's what you want to exclude, okay? You're now thinking in the right way, okay? That's really good. And in this lady who's 35-year-old coming with right lower quadrant pain, it's
okay. In lady, we have to exclude torsion ovarian cyst, hemorrhagic cyst. So acute appendicitis, we have to exclude.
Okay, what is the other thing that you have to exclude before that? The serious thing. There's something saying
ectopic, maybe ectopic. We have to do
ectopic, definitely.
Yes,
So
you have
all
to
what
do
you said
ECG.
is right. Is not that's a very good answer, but and that's why we ask for pregnancy tests for all of them, all women.
Yes, it's mandatory in all females.
Yeah, yeah. That's why we ask for it.
Mandatory.
Okay. What about this guy, 27-year-old male presenting with left loin pain? What's the likely and what do you want to exclude?
First, about this old male, we have to ask about the bowel habit of this because of old age. Okay, I have to exclude there's any cancer like this.
Okay.
If any diverticulosis.
Okay.
But first we have to exclude change in bowel habit. Okay.
Okay. That's
and the most common here is diverticulitis.
Okay, it can be diverticulitis, but loin pain is typical a bit. So the examiner is not going to disagree with you. Okay, but loin pain is known with urological issues. Okay, but in old elderly men in Western world, you have to exclude AAA. Okay, the aortic aneurysm. That if you said that to them, okay, that's fine. They will go for the next step, definitely, immediately. Okay, because this is a very well known question, by the way, MCQ question in the FRCS. Okay, and very well known thing when someone came to ANA to me, before I accept this referral, I have to make sure that they've done at least ultrasound to exclude aortic aneurysm. Okay, in elderly men. Okay, if not a CT scan, by the way. Okay, so that's something very important. So you have to bet this is something. There is a likely diagnosis, yes, but there is something else I need to exclude. Okay, 57-year-old lady, severe epigastric pain. It can be an ulcer. You said that, yes. It can be something else. It can be pancreatitis. And in this lady and the other guy, it can be what? Cholecystitis, it can be. And the other guy, this 65-year-old male with severe gastric pain, what might be the answer?
MI or maybe
Definitely.
pancreatitis or aortic aneurysm.
MI, definitely. Okay, so we have to exclude it, definitely. So I don't, here I don't accept referral without ECG and sometimes troponin. Okay, so this will be how we're going to answer the first question in your station. Okay, so in this case it can be pancreatitis, that's why we'll ask for amylase. Okay, and ECG, okay, to exclude cardiac event, and something else which is common nowadays, we're in a pandemic or something, so a chest x-ray. Okay, to exclude lower lobe pneumonia. Okay, I've seen people coming and refer to me as cholecystitis, but in fact they have right upper quadrant pain. Okay, but in fact in reality they have lower lobe pneumonia. Okay, so you need to think about that. And in the 5-year-old boy with lower abdominal pain with diarrhea, that's tricky a bit, but it's a known MCQ question as well. I don't think it will be asked in your Osce, but just I found the opportunity just to put it here. Okay. It's you have to bear in mind that this boy might have pelvic appendicitis. Okay, so don't worry about it. I don't think they will ask about it. Okay, they just have to bear it in mind. Okay. Chest x-ray, anyone can comment on this chest x-ray? Okay, so yeah, you can do that. Nandan, sorry.
Doctor, this looks like pneumothorax.
Okay. Why you said pneumothorax?
Can I answer, please? I'm sorry, I have a noisy background.
Okay. Very well done. So can Isra answer?
Yeah. Yes, there is an air at the diaphragm.
Okay.
So we think of perforated viscous or something like that.
Okay, fine. You're right. You're absolutely right. So in order not to miss things in X-rays, you need to have a system, okay? You can choose a system, okay, yourselves, or you can follow my system, or whatever system, okay? You can go, you know, when you ask in the exam to have a look at the X-ray, you need to show the examiner that you have a system, okay? One of the systems is the ABCDE, okay? And one of the other systems is go from outside in. Okay, so I wasn't planning to explain this in this lecture, but I'll go through it very quickly. Okay, the ABCDE is airway. To have a look at the trachea, you can see the trachea, this blackish thingy. Okay, and you can see the right main bronchus and the left main bronchus. Okay, and B is the breathing, the bronchovascular markings. If all bronchovascular markings reaching to the thoracic wall, okay, and there is no blackness or anything like that, you can see bronchovascular markings till the end, so there is no pneumothorax. Okay, hemothorax is white, pneumothorax is black. Okay, so there's no whitish stuff in the costophrenic angles. Okay, so that's B. C is circulation, which is the heart. Okay, you see how big is the heart and the mediastinum. Okay, D is the diaphragm. You go for diaphragm and comment on the diaphragm. Here you can see that there is air under the diaphragm, there is air above the liver. Okay, so that's a perforated viscous. And E is extras. You can have a look at the extras and ribs and stuff. Okay, so when you show your examiner that you have a system, okay, and you've been through all of these things, you said A like that, B like that, C like that, D like that, and E like that. So you're not going to miss anything. That's a perforated viscous. So this is our guy's X-ray, okay? But this guy likely will have a perforated viscous, isn't he? And if this guy is hypotensive, tachycardic, clammy, diaphoretic, you'll be shocked and you'll be asked what shock maybe, which type of shock, and you'll start questions about sepsis and how you manage sepsis. And this is just to put you in context. This is the journey of the laparotomy patient in the UK hospitals. This is taken from the most recent publication about something called NELA project, which is the National Emergency Laparotomy Project. This is how the emergency laparotomies or peritonitis patients run through the system. They just comes and they have sepsis management, and there are some targets. You have to give antibiotics within 1 hour. You have to do a CT scan within a time limit. They have to have a consultant review in the time limit, prompt consultant review. They have to have what we call risk assessment. You can speak about that later. And theaters need to go to theaters in time frame. They need to have a consultant surgeon and consultant anesthetist in theater, or at least involvement. Critical care in some occasions, if the risk assessment is more than 5% mortality, they have to have frailty assessment and then think about discharge. Okay, I know I've been through a lot of things, okay, but I'm just trying to put you in context, okay, and I might raise more questions than answered more, answered questions, okay, but I'm just trying to let you know how your examiners are thinking, okay, and what they are expecting from you, okay. I still not discussed shock. I've not discussed sepsis. I still not discussed other things and what we're going to do for this patient, all these things, but I will leave that for another time, okay. It's just to, some sort of brainstorming for you. Okay. Thank you very much, and we'll see you another time.